Oh, hello, everyone. Please understand that by time I have got an extraordinary capacity, and that is to remember each one of you. So I'll see you all next year at the next EIO and greet you. Is that nice? Yeah? So please make sure to note next year we'll meet again and I'll recognize you. Having said that, I had one more important thing to add before I leave stage.
Please say it.
Yes, and that is, please note that there is a specific application for posing questions later on. So app.eao.org. Use that app.eao.org to pose questions about the presentations you will be about to hear. And having said that, I leave the floor to my co-chair, Turker Ornekol, who will present the first speaker.
Thank you very much, Björn. It's always a privilege to be with you on the stage and fun to be with you on the stage. As we have announced that the main topic is related to time, before starting or before announcing the name, I would like to say a few words with the topic, related to the topic. Time is something that touches every aspect of life. Biologically, it governs the growth, healing, and aging. And psychologically, it structures the memory, interpretation, and identity. Yet, we don't know what time is. And even if it does exist, we don't know that.
Life. And it is my great honor and privilege to introduce to you. I read it here to make sure that I get the correct person. It's Howard Gluckman, who we will invite here. And Howard will tell us about the evolution of surgical techniques in implant dentistry over time. So please welcome Howard. Welcome, and we look forward to your presentation.
Thank you very much.
In time.
Thank you. It is truly a privilege to be here today, and thank you to the EAO, the SFPIO, for the invitation. What a pleasure, what an honor. But what a difficult topic to talk about in 20 minutes, to give a TED talk. So thinking about this topic, the impact of time on dentistry, one had to make this more a philosophical lecture, more than a lecture about specifics, because you don't really have the time to lecture on all of these things. So the first question that I asked myself when we were doing this is, what is time? How do we look at time? How do we figure out what time is? And time really can be a couple of things. It can be speed. And Frank, you spoke about speed and how we're trying to slow things down, but essentially not. We're trying to speed things up. Our patients want their treatment faster. We want to treat our patients much faster so that we have a much better patient happiness with the treatment. We want to get our return on investment on everything that we do. We want to create sausage machines for some of us. But ultimately, what we want to do is we want to create precision. We want to create ideal treatment, and we want to do it faster than we did before so that we can create better workflows. But on the other hand, we are also looking to get longevity. So which one is it? Is it longevity? Is it speed? Or perhaps it's a little bit of a mixture of both. So let's have a look, because time has certainly developed our techniques. There is no doubt what we did 20, 30 years ago, we are not doing today. And yesterday's technology is today's rubbish, is snake oil juice. But the question that I ask then is, what shapes all of these things? And that's what I want to spend a little bit of time going through, is what shapes all of them. The first one is our technical innovation. The second one is biological understanding. Treatment planning evolution. Holistic patient well-being. And the last one I've added is access to knowledge and research. Now, I want to be very, very clear that these are the ones that have affected me, and there might be many, many others that you want to put into the scene. Say, Howard, listen, you haven't mentioned this and you haven't mentioned this. I apologize. But these are the ones that, in my mind, make a huge difference. And as you can see, all of these factors together come together and work together and help us to develop our techniques and our technologies and our understanding over time. For many, many years, all of these factors have been working. Sometimes biology's been further, sometimes our understanding of treatment planning has been better. But at this point in time, what is winning the race? What is getting there faster than anything? And it appears to be technology. But just because technology is winning the race does not mean that we are taking away from everything else, because there's such a strong interplay, as you will see in the next few minutes, around all of these techniques together. So let's take a moment and let's look at technological innovation. Let's spend a bit of time going through things that have affected me personally, and there's many, many more that we can. And CBCT and intraoral scan, for any surgeon in the room will know that when we transitioned from panorex and periapicals to CBCT, it was like a light bulb moment that went off in our heads. It was amazing how clearly we could see things. And it's funny, Ben, because you go so far out, we go so far in. You know what I mean? It's like, wonder how small our minds are. We're looking inwards. But CBCT, the second thing, static guided surgery. Everything about precision, about speed, about getting everything in the right place with much quicker treatment for our patients. Our patients are happier, but not only are our patients happier, but we're achieving better results. And we all know that 3D implant positioning is one of the key factors for failure that we have these days. And there's the technologies brought around to fix those. Stackable guides and provisionalization has been another leap forward for our full arch cases, where we're now able to plan backwards, firstly developing smiles, then from smiles going backwards to teeth. We used to work in the old days, placing implants where the bone was. Now we are placing implants where the smile and the face is. Dynamic navigation. Another huge step forward, allows us a little bit more maneuverability when we're working with different plans. We can change plans on the fly. We can use different instruments, which is a very, very cool thing. But by the same token, it is a huge learning curve and a little bit more tricky. But it shows that dynamic and static navigation, we know from our data, gets exactly the same result. But this is the big one. Robotics, artificial intelligence, and biotechnology. And these are really the three things that are really going to be the massive change in the future for us. Robotic surgery is already here. It's already shown, there's good data to show that robotic surgery is far more precise than any of the other types of surgery that we use. Artificial intelligence, I'm sure every one of you will agree, it has absolutely infused our worlds. And it's not just ChatGPT. Every aspect of what we're doing is now utilizing some aspect. From our back office desk to our front office, to every aspect of diagnosis, early diagnosis, in everything that we use, it's infusing itself. And biotechnology is another factor. If we look at biotechnology today, biotechnology is coatings. What coatings can we apply to our implants that are going to improve our osseointegration? And believe it or not, at the University of Pennsylvania, they're already doing nanobots. There's iron oxide that they're using, iron oxide robotics, where they are using these little nanobots with magnets that allow them to go into biofilm, small areas, and clear up the biofilm. But not only clear it, but actually remove the biofilm, which is the first time that we've been able to do that. How will that technology come into the future? All of these things come together, and where will they converge? Because we're going to change from being reactive to proactive. And I think it's very, very exciting. I think for those of you who've been in the technology for so long, I'm actually upset that I'm not 20 to 30 years younger, because I think the youngsters of today, what they are going to experience in time, it's going to be unbelievably exciting. And I think it's a very exciting time to be in dentistry. If we look at biological understanding, abutment connection, and Steve Chu's going to talk about this a little bit later, crown design, all of these things are important. We've understood that when we change this, we've been able to stabilize our marginal bone loss. So gone are the days of that 96 Zarbon-Albrechtsen paper that showed us what success or survival of implant was. We can now maintain that bone. Post-extraction socket management. We understand better now what post-extraction socket management is about. And there are great lectures that are going to come at this conference where we'll be able to learn and understand and predict better our surgical case. Carl Misch and Odette Bahad, a number of years ago, started talking about midfacial growth and the changes that happen in midfacial growth. And understanding this is going to also change, and there's a great lecture this afternoon where they start to talk about midfacial growth and how that will change our treatment strategies, how we will start to delay our treatments as long as we can to make sure that we don't have this problem, but also communicating with patients to let them understand that there might be revision at future dates. And of course, my all-favorite is partial extraction therapy. Marcus Hertzler's technique of maintaining the buccal plates and prevention of that buccal plate, which in my opinion is one of the greatest inventions that has come along to be able to prevent the post-extraction socket collapse that we've had and keep it over time. Treatment planning evolution has been another phenomenal plan. From having our digital avatars and taking our patients home, that we can actually work with them in home. We can look at mouth, we can look at smile, we can look at every aspect of them. We do not require our patients to be there anymore. From Christian Coachman's digital smile design, where he has enhanced the whole concept of facial aesthetics versus bone placement or prosthetic placement of implants, we are now starting to utilize this technology, not starting, we are well into utilizing this technology, where we now understand that this technology is what we use to make sure we understand where must our bone grafts be, where must our teeth and our implant positions be, not where the bone is and not where the tooth is. How that tooth fits into the face is now more important than anything else. This is taken now one step further from Florian Kofar from SmileCloud, and a cloud-based system where you can now do all of your management, your development of your smile. You don't have to leave this to your technician. How often do we leave this to our technician and we have no input, which is not the way to go? It should be a combined multidisciplinary plan that gets us where we want to go. And the most phenomenal thing that's now introduced is this AI, where we can now get patients we can just do our design and the AI takes over and allows us to see what they look like and allows the patient almost instantaneous to see what they look like. We still need data to show that this is right, that we can see this when they compare reality to what the design does. But this is really a major jump forward and a leap forward for us. And I think we can't go forward. This is one of my favorite from Luca de Savola, the guided bone harvesting, because this is all about reducing time within surgery, making things easier for us to work so that the patient workflow is much faster. We get much happier patients because we are able to work faster, but not faster in speed, just more productively. And this is such a critical thing, and there are many different types of guides that have been done, but this is really, from a surgical point of view, one of the best. What about holistic patient well-being? How often have you said to your patients, you have a very clear idea in your mind about what you want to do? You know, I'm going to put bone here, I'm going to do this, I'm going to do that, then I'm going to do this. Now you have to now communicate this to your patient. And think about that. You now sit there with your hands, and then I'm going to do this, I'm going to put this over here and do that there, and you think they're understanding you. And they look at you like you're some kind of idiot because they're on a different planet. The technology that we have has really changed this completely. It's thrown it on its head because it allows us to show them exactly what we're going to do. We are able to now visualize exactly and put that across to our patients so that we are able to see and they become part of the process. And what does that do? It builds trust. And the more trust that we have, the better our patient base is going to be, the better our work is going to be, because the patient is part of the process. We cannot leave out airway dentistry, which is such a critical factor. Airway dentistry used to be the domain of ear, nose, and throat specialists. But now our understanding of tooth position, jaw position, tongue position, palatal growth, all of these factors have become a major issue in our diagnosis and treatment planning, that we now understand that this has to form a part of everything that we do. When we're putting implants in, when we're doing an all-on-X, all of these factors have to be taken into consideration to make sure that we don't make a mess. And systemic dentistry. This is something that's growing very, very fast. How often do we think of what the oral biome, and especially Porphyromonas gingivalis and Fusobacterium nucleatum, how do those inflammatory mediators and the gingipains that Porphyromonas gingivalis produces, we understand now that those end up in the brain. Alzheimer's, how all of those periobacteria go down the body and they affect inflammatory bowel disease. How some of those bacteria are present in rectal cancer. So understanding all these biomes and understanding how we can use salivary measures to detect these inflammatory markers is absolutely crucial. And this is my favorite, access to research. And I think this has been the biggest change for us, is that we've got PubMed, we've got Cochrane reviews, we've got all of these fantastic things. So what's happened now is we've sped up the spread of data, because before you used to have to wait to get your journal from the EAO. And in South Africa, it takes about a year. We get the 1 year later. Okay, and then when you get it, it's like buying a CD or an LP. For those of you who remember what a CD or an LP is, some of you won't remember. But in those days, you had to buy music, you had to buy the whole CD, and you got all the songs. You didn't want all the songs, you just wanted one. And it's like getting the journal. You didn't want all the things because nothing was relevant to you. Only one was relevant to you. Now we are able to go onto online access. We can buy these things. And the nice thing about this is not just the privileged few that can buy it. It is available everywhere. Anyone can buy it. And we have to bring social media into this, because social media is also a factor where we can learn things. And I've learned a lot of very, very cool techniques on social media. All of these things have a really fantastic ability to give us stuff, but there's a huge but. And the but here is this. Open access, paying for your journal, means that there's also false advertising. There's false news that can be given. So some of the journals are not really journals. The peer review process is not followed. And social media is also a huge factor, because with social media, and I took this off the internet, if you're in the crowd that did this, I apologize, I don't mean to demean you, but this is something that's really happening, where you can see teeth are taken out, ostectomies are done, making the patient with nasal lift. Why? And the craziest thing is that the comments of positivity on this case are like, wow, wow, what a great case, you're an amazing surgeon, amazing. Where's this going to be over time? So my question to you is, have we traded preservation of our teeth for presentation? That one photo on social media that looks fantastic, because what's going to happen to these photos over time? I look at my case 12 years later, full arch, FP1. Am I going to be saying how wonderful this is 25 years later? Is it still going to be looking the same? Or do I now put this in my bottom drawer and you never see this again? What happened to that case, Howard? No, patient never came back. So I'm going to share this case with you, and I want you all to open up your phones now, because we're going to have a poll. Please open your phones. There's a poll on your app. Everybody open your phone. Come. Open the phones. I want you to look at this case, and I want you to treatment plan this case in 5 minutes. Okay? How would you manage this case? Would you manage this case conservatively, or would you manage this case all on X? And I'm going to give you 30 seconds in which you can talk about what you prefer. All on X, perio, ortho, crown and bridge. You have to vote. Please vote, everyone. The more you vote, the more impact it's going to have. If you don't know, go into the app online, and you'll find online there'll be the polls. You'll see the question. You're not going to see the result just yet. It's going to come up on a Okay, they'll show us. I'm going to give you a few more seconds. Please be voting. All right, and 3, 2, 1. Okay, we move on. Okay, so it's going to be interesting to see what the answer here is, but I'm going to take you now to this case because there's a very important point I want to make. And this case is courtesy of my friend Maurice Alama, because this case went through initial perio. It went through orthodontics. It went through periodontal splint. A Morton Amsterdam bridge was placed, okay, with copings, with ceramo metal bridges. And if we look at the before and the after, pre-op and post-op, great result. But what does it do in time? 28 years later, All that's happened is they've lost a molar in the upper right-hand side. Everything else that had so much perio and so much bone loss is still there. Can you do this with every case? Of course not. That's not my point. The point is you can do it with some cases, and I think we have gone too far. We are now starting to remove teeth that do not need to be removed, like the case I showed you earlier. And if you look at this case 28 years later, pre-op 5 years, 28 years, is that a great result? Is this patient happy with what they've achieved? Without a doubt, this is a success. So to finish off, only time determines our success. So all this technology that we have, we are racing ahead with technology, yet we have no idea whether this technology is going to give us any benefit. Are we going to have the results? Is it going to make such a big difference in the future? Who knows? But I do know one thing. Some of my own long-term follow-ups, 19 years and 25 years, they're not pretty. And my answer to you is, the more I place implants, the more I want to save teeth. And the ultimate, teeth are timeless. And I thank you very much for your time. Let's have a look what the results are. Okay, so the results, fantastic, because the results, I think you all knew what I was going to say here, so you gave the other answer. Yes, that's not cool. Because I think if I hadn't showed you any of that, anyone here would have said all on X. So all on X was 14.88%, perio thing 83%. So I take my hat off to the audience, because if that is what you think, then your mind is in the right place. And with that, to the EAO and to everybody else, thank you so much. It has been a privilege.
Thank you. Thank you. Thank you, Howard. It was like a time travel into the dentistry. Now, we know that time shapes every issue related to implant dentistry, from healing and loading to long-term success and our patient expectations. It defines success and or failure. It defines how we evolve as professionals. Now, let's listen Dr. Stephen Chu, who is one of the well-known prosthodontists coming from United States, to see how time defines and controlled in implant prosthetics. Stephen Chu, please on the stage.
Thank you. Thank you, Turker. Can you hear me? Oh, great. Thank you. Thank you for inviting me to the organization. Howie, so nice to see you. Ben, that was pretty amazing as far as time. And again, thank you to the organization and having this joint meeting. It's so nice to be here. In regards to the organization, Turker and I had a conversation on the phone. So he asked me to be somewhat specific in regards to prosthodontics, because I'm a prosthodontist, I don't do surgery, and I think that's sort of an important message in that regard. As far as disclosure, I'm not receiving any corporate sponsorship. I haven't falsified any of my images, and I do have company relationships with various companies, and we've worked with companies to help improve our outcomes. In regards to what Howie said about the more he does implants and the more wisdom and time, he's saving more teeth, I agree. I think that some of the things that we're doing now in implantology and cutting off the ridge just to place implants and make it more efficient and simpler and more productive, I'm not so sure that's the way to go, but we can have a discussion about that later on. But this is an implant meeting, so we will be talking about implants. I had a chance to be with my classmates, Stefano Grazias, last weekend in Milan, but one of my classmates who was behind me in University of Washington is Bruno Fessor, and he actually practices and lives here in Monaco. So it's so nice to see friends and classmates over the time. And I was so happy to see that the casino in Monte Carlo, where Casino Royale, the James Bond movie, was filmed. And I told my wife, I said, oh, I saw the casino where they had the movie. So it's what a spectacular place here in Monaco. In my group practice, Dennis Tarnow, most of you know him, says hello, warmest welcomes and warmest regards. And my daughter Stephanie, who practices with us a couple days a week, so I get to see my younger daughter. And we have a great lab group as well. And without their help with the evolving technology, it wouldn't be happening. So we'll have a discussion about that. So again, Turker asked me to speak about this, the evolution of where we are with prosthetic techniques and technology and how it's affected us over time. So our conversation was really revolved around that. So I'll try to be much more strategic, Ben giving a very big view, Howie, and then I'll just try to be a little bit more focused on some of the aspects of prosthodontics, how it affects us. And I'd like to just focus a little bit more on the single teeth work that I've done with Dennis and Christian Hasse, but it also applies to, obviously, multiple unit situations. So let's talk about immediate provisional restoration, because that is a time-dependent factor. Immediate therapy is really trying to streamline time, and I think that's important. So what are some of the prosthetic things that we can do in that area to try to streamline and get more consistent outcomes? I'd like to talk about prosthetic contour and its effect, because we have to deal with digital scanning, and we have to talk about abutments and abutment design, and what about prosthetic contour? Because that's sort of the overall effect that we have to really deal with, and I think that's very important. And then I'll try to tie up some of the conclusions within the 20-minute time period. Let's talk about immediate provisional restoration. Immediate implants has become very popular now. It's been over 20 years that it was really talked about by Peter Worley and then Joe Kahn. So it's been around for quite a long amount of time. Dennis and I have evolved toward it because we find it's very efficient, but the reality is that it does work. And so we've been very involved with this over the last decade or so. It's really about preservation and the concept that Joe Kahn talks about, immediate implant placement and provisional restoration is some of the key elements. And if you speak to Dennis, right, Helena and Jose, it's really about one surgery, one time. So it does reflect around timing. It's about efficiency. But if you ask most patients, would they rather have 3 surgeries or have one that achieves the same goals? They would probably say one. And that's some of the key things that we do. There is now compelling evidence in the literature that is looking more long-term at outcomes, especially aesthetic outcomes as well, not just implant survival, but aesthetic outcomes. And it's now reporting that the aesthetic outcomes are equal to or even better than delayed. So here's some examples of some long-term recalls in some patients we've treated with immediate therapy. Tooth number 11 for this particular patient. And this is a 15-year recall, also on tooth number 11 on a different patient. So the longevity and the time, and just watching Ben's presentation of what Earth will look like in 5 billion years, it doesn't look so great, obviously, but the reality is that time does define our success and failure. And that's the truth of the matter. Time just defines if you're good or you're not, and if you make some mistakes. We like using this technique for immediate therapy. We like doing dual zone grafting. You can do connective tissue grafting as well, but we really like to incorporate Paul Weigel's prosthetic socket seal, which is really a prosthetic aspect of how we deal with immediate implant therapy, where we can use the prosthesis to contain and protect the graft during the healing phase of treatment, allow for maturation, and then we've been able to preserve the shape of the ridge and improve our peri-implant soft tissue. This technique works extremely well, but if you're not grafting where the soft tissue is, you have to place a connective tissue graft, something that Iñaki Gambarina and Zucchelli talks about all the time. So that is something that we find, but it does require the prosthetics to be done. And we like making full temporaries because we can contain and protect the graft and give the patient a tooth when they leave. So again, this technique works extremely well. And in all the studies we had done, we found that the amount of ridge collapse was minimal, less than 0.5 millimeter, but we were able to gain about 1 millimeter of peri-implant soft tissue thickness, not unlike what Joe Kahn showed with connective tissue grafting. But this requires making a provisional as well as graft containment with something that's anatomic. So that's some of the aspects that we have to deal with. When we're talking about immediate therapy, we have to talk about how much gap you need. This is a great paper by Bob Levine that talks about how much gap you need. He compared 2 millimeters or less or greater than 2 millimeters, and he found out that even with internal socket grafting, you need more than 2 millimeters in order to gain a net of about 1.5 to 2. The net of 1.5 to 2 is really reported by Monhe's group. I actually saw Itzvan in the hotel with his little son. And this is a great paper because it sort of lays the land of the law to say, well, how much bone do we need to have in order to have good long-term outcomes, but also resistance to periodontal breakdown? And this recent paper says that you need greater than 1.5. So if you put all this together, these are some of the nuances that we have to really think about in order to achieve this properly. This is probably one of the best papers that talk about what's the value of the prosthetic aspects in regards to prosthetic socket seal. Crespi has done a lot of the work in this area. What was very interesting, he looked at two groups. One, he placed an implant, and then he grafted around it and put a membrane. And the other one, he just made a custom healing abutment. No grafting. So implant placed, temporary custom healing abutment, no grafting. The other group got all the grafting, all the suturing and everything, but no custom healing abutment. And he actually showed that the best outcomes in maintaining ridge shape and volume over a 4-year period was actually just making a custom healing abutment. In fact, the group that had all the surgery done after 4 years, this is a 4-year study, that showed that the group that had the surgery with all this grafting had 1 millimeter more recession and 2 millimeters more collapse. So the value of the prosthetics, maintaining the ridge volume and shape, and also maintaining the blood clot, provided that you have all these other elements in place, that physical support was critical in being able to afford better, consistent outcomes. So when we're talking about custom healing abutment, what devices do we have? This is a system called the cervical system, but you have to select and make the prosthesis yourself versus some prefabricated components that you can take out of a box and it'll accomplish the same goal. So there are very different types of products that are out there, but the general concept, at the very least, is that you have to make a custom healing abutment. We like making teeth because patients walk in with a problem and they leave with a better tooth or a tooth that will be more consistent later on. So these are some different components. These are gingival cuffs that are prefabricated, or the gingival cuff can be combined with the temporary cylinder. So these are some of the different products that are available. In regards to the gingival cuff type of concept, it's a 3-piece system because you have a temporary cylinder, you have the cuff, and then the tooth facing. With these other products that are sort of combining the anatomic component, it's basically a 2-piece system, and a 2-piece system saves you time. And that's the whole thing, just being more efficient. So that's some of the aspects that are out there, and then you can get very consistent results in order to create anatomic restorations that will contain and protect your graft. So if you take a patient like this, where you can then place the implant, again, we can make this type of temporary device for the patient. These are prefabricated, so you can just reline the tooth on top, so it's a 2-piece system. Then outside the patient's mouth, you can fill it in with whatever material you like, composite, acrylic, doesn't really matter. And then you could shape it up accordingly. And then you have something that's anatomic that will replace the patient's tooth. And in combination, like I said, with prosthetic socket seal, so the provisional acts as a prosthetic socket sealing device with Dennis's dual zone concept, we can contain and protect the graft. And then after healing and maturation, we can get consistent outcomes. And I think that's one of the key elements of when we're looking at that. And what's the value of the prosthetics? What is the prosthetics doing for us? So the component of the prosthetics, I think, is very important. And again, the work from Paul Weigel from Germany and his wife. Well, what about the effect of prosthetic contour? I mean, prosthetic contour has become very complicated. And the old saying, I'm sure that most of you who are prosthodontists, you know, prosthodontists, we like to overcomplicate things to make ourselves feel a little bit more important. So the old joke is like, prosthodontists, you know, they just tend to make things overcomplicated. But it is complicated, as you'll see, in regards to how we're marrying all these aspects with digital dentistry. And I'd like to really talk about prosthetic contour as it relates to stock versus customized abutments and custom design. And with digital dentistry now we can do a lot of different things. So this becomes, I think, a very important and relevant conversation in regards to what about the subcritical contour of our restorations, and what about decementation of components that are on top of some of these prosthetic parts and pieces. And I think that's really the two aspects that I'd really like to really talk about much more in detail. So let's talk about subcritical contour in this regard. The contour is really something that's been around since R. Sheldon Stein. I talked about this before. And how we relate this to implants, this was really worked on at UPenn with Ernesto Liu's group with Dr. Su. And what they did is they defined what the subcritical contour is. It's really as the restoration exits the platform of the implant, what is the contour as it exits the implant? And then the critical contour would be from the CEJ to the free gingival margin, where you would contour the restoration to support the tissue. So there are really two aspects. One would be more aesthetic with the critical contour. The subcritical contour would be what is exiting the implant. And I think that's what's very important to discuss. We obviously have all these stock components, so companies give us these stock components, but a lot of these may have a low profile, but they have a very, very wide lip. And that wide lip can actually be an obstacle in some situations, as you'll see. But these are some of the stock components that are presently available. I had used one on this particular patient, and for the life of me, I couldn't seat the restoration. I had to take an x-ray, and I realized that because of this contour, this subcritical contour of that exit from the implant, from the stock component that was an original manufacturer, that I wasn't able to seat the restoration. Consequently, I had to modify that and thin out the area. Now, the question I had is that, did I compromise the strength of the restoration in that area in order to have a better subcritical contour so I could seat the restoration? I don't know. There's studies to actually look at contour as it relates to potential bone loss. And these are some studies that sort of allude to the fact, but I've actually seen a lot of these patients in my own practice in regards to, well, if we don't have the correct subcritical contour and we're using a stock component that the company recommends that we use, is this actually going to work for our patients? And this is something, is it beneficial to the patient? How about a patient like this? Jenna, she walked into her practice. We hadn't placed this implant. This is what she ended up with. This was after a couple years that she had the restoration in her mouth. And consequently, this is what it looks like. And you can see the contour. Okay, Jose may say, well, that crown really doesn't have a well-fitting margin as well, but just look at the tie base and the really wide component of the tie base. And could that be an obstacle then for hygiene? I mean, these are some of the questions that can be posed in reference to some of these aspects. Well, how about this? This is one of my cases. I did a screw retain restoration on this particular patient. We used the stock component, but this is what it looks like. And for the life of me, I couldn't figure it out because the patient kept on complaining, said, it just doesn't feel right. It's painful. Something's not right. And I didn't react quick enough, so I was a little bit late in timing. You could see how this component is over-contoured. It's actually a reverse platform switch. It's much wider, and that puts pressure on the surrounding bone. What I didn't realize is that I was probably causing pressure necrosis because it was the wrong contour. She comes back 3 months later, the damage is already done. I may have changed the contour, but the damage is already done because I caused bone resorption because of subcritical contour of maybe a stock component. So I think there has to be some better understanding of what can be done, and hence digital dentistry has allowed us to do a lot more things because now we have the ability to custom design and fabricate our own restorations that may have a better subcritical contour so that we don't put pressure on these tissues or make it easier for patients to clean so they can exhibit better hygiene. In this paper we had published, we talked about at least having a straight emergence profile from the restorative interface anywhere from 0.5 to 1 millimeter. The key is that the subcritical contour should not put pressure on the surrounding hard and soft tissue, and the contour of the restoration should allow the patient to clean properly, whether you're making a cement retained restoration or a screw retained restoration. So I think digital has really done a great job in allowing us to do much more of these different aspects. So again, subcritical contour, custom design versus stock, and something to really think about and do that. Well, how about decementation? You know, that's another factor that we have to deal with, because when we're doing all these different components and, you know, what do we have to choose from, I think it becomes pretty important. And this was some very good papers that actually looked at this. Ibrahim actually looked at ASC versus non-ASC components, but Ibrahim basically said the following, is that if you have more surface area to cement to, then that will be more resistant to decementation. It just makes common sense. We know that with resistance and retention form for crowns that we do on natural teeth. Irina Sala did a very nice paper looking at all the different aspects. She wrote a paper in Periodontal Perio 2000 that looked at implant complications. And what she reported in the literature was that the rate of decementation was anywhere from 3 to 7%. Say you're at 10%. That means that 1 out of every 10 will decement. In fact, what I've seen in my own practice, that my decementation rate using stock components on molar teeth with very, very large interclusal space and very short tie bases, I would say that I have systematically replaced every one of those restorations over a 5 to 8 year period. They just keep on coming back, and I just have to redo them and replace them. So how do we replace some of these restorations? Like I said, it's not just the subcritical contour, but it's also the ability to customize it, and customization gives you more surface area for bonding and cementation. So I like doing that because I find that I can control all these different aspects, but the most critical part with digital dentistry is that by custom designed abutments, we can increase the surface area and improve or reduce the risk of decementation. How about something like this, where we have all these different components? Now, sometimes you're locked into different aspects that you have to use some type of stock component. But you can clearly see that with a customized component, you can control the critical contour. You can move that lip or that ledge more coronal. If the implant is placed at a deep enough level, then you could actually have that in metal. If you have thick enough tissue, it won't show. Ronnie Young's work. So there's a lot of things that you can do with that. And I think with digital dentistry, it's now afforded of that. So again, you have the ability to change the subcritical contour. You can improve the surface area for cementation, and you can have a very consistent result, whether it's a single tooth or now with multiple units. Now, I don't want to get too crazy when I show some of these things, but what I want to do is talk about original equipment manufacturer versus third party. And what all the studies basically say is that if you have an original component from a company, that will give you a better outcome. However, they did say that third-party components, which would be third parties like Atlantis or Bedentica, which is now part of Straumann, or these other companies, True Abutment, Preet, they all will allow you to design an abutment, but they'll certify it for you. So a certified component is just as good as an original equipment manufacturer, because that will also be warranted. So it's gotten a little bit confusing, and I'm purposely putting in these charts. This was done with my technician, Jamie, who really looked at this. And we looked at stock, a stock ASC. Could we customize it? Could we make a custom ASC? Does it have pre-milled blanks? So that's the categories we looked at. And these are just the manufacturers that we're familiar with in our own practice, but there's obviously many more. So the checks and X's basically tell you whether or not you can do that. If you look at Straumann and Nobel, they give a lot of different options, which is quite nice in that regard. So if you're using some of these systems, that can work very well. If you're not, you're going to have to go to a third party that will certify the component. And these are the third-party manufacturers that we work with in our office. The same criteria: stock ASC, custom, a custom angulated, abutment, or pre-milled blanks. These are the different companies that are presently out there. If you use them, please make sure that you're getting a certified component, and they will certify it. These are abutment companies that do very well. And the two systems that we're most familiar with is using the true abutment or the Preet system, because it gives us much more flexibility than some of these other third parties. It's complicated, like I said. It gets very complicated. Maybe at the discussion we can talk a little bit more. But like I said, I'm a prosthodontist, so we like to overcomplicate things. But it is complicated. So I just want to finish up with Max. He comes in like this. He had a crown. He has this fistula. A couple years after having the restoration put in, you could see this stock component. It is skinny, but the subcritical contour is too close to the bone, and you can see here that it may be difficult for him to clean. He has a fistula. Maybe he had pressure necrosis. It's hard to determine, but this is not the design that we would want, even though it is a stock original equipment manufacturer that's recommended. So like I said, we used a third-party component in this situation, a scan body. We can then custom design an abutment, and in this situation, we were able to also do a custom designed ASC component because he needed a little bit of angle correction with that as well. So you have to understand which company will allow you to do which things. We can then control the contour of the restoration, the subcritical contour, and then we could have enough surface area for proper cementation of the superstructure so we don't have the issue of debonding or decementation. And that's how we can sort of combine some of these different aspects in regards to some of the newer technologies and some of the aspects that we as prosthodontists have to face. So in conclusion, custom healing abutment or full provisional restoration is important to support the tissue volume during healing, also for graft containment, and how some of these newer concepts can help us along the concept of immediate implant therapy. It's about saving time, one surgery, one time. Works extremely well. I like using custom designed abutments because it allows us to really control the proper subcritical contour as it's exiting the implant. And if the implant's placed at the proper depth and level, then there should be no reason why you can't be able to do that aspect for your patient. And it also allows for greater surface area for cementation, so we don't have the issues of decementation. I look forward to the discussion that we have. Hopefully you've had a different view from Ben, the big view, and Howie then trying to give an overall view, and me as a prosthodontist, like I said, overcomplicating things, but being a little bit more strategic to try to hone in a little bit more on the dental aspects that we have to face every single day. Thank you for your time and the invitation.
Thank you so much. Thank you so much, Stephen Joe. And of course, given the presentation by Ben, you may think that who cares about timing? Being a chairman on a session like this, we have billions of years to just relax and sit there and wait for time to go. But we have a deadline here. It's just a few minutes more. If you have some urgent questions, please make sure to send it. And while waiting for the questions, I have two questions. First one, a surgical question. What is the take-home message today of time when it comes to surgical procedures? I mean, we went from wait 3 months, 6 months, depending on it was maxilla or mandible, until teeth in an hour. What are the take-home message when it comes to timing and surgical procedures?
I think to answer that question, there's no fixed answer. I think it's a case by case and a horses for courses type of situation. In some cases where you have bone, some cases where you have technique and technology, you can do it a little faster. In some cases, it's not able to be done. I think the most important thing about take-home is that don't try and fit everyone into the same box. Choose the right case and you will be able to get the right result. You'll be able to do things as fast as possible. You'll be able to immediate load. You'll be able to do immediate provisionalization, either full arch, or smaller provisionals, etc. But I think the key is choose the right case, choose the right technology for the patient. If all you have is a hammer, then everything looks like a nail.
Okay. And again, basically the same question in the prosthodontics. Is it possible to get some strict take-home message here? In addition to the splendid presentation you had, what should we think of? The question is, what are the critical time points to think of when it comes to prosthetics? Are there any, or is it individually based?
I agree with Howie. I think I think it's all individual based. Even whether we select socket shield or do some of the other techniques, it's really patient dependent. So I think that's some of the aspects that we have. A friend of mine said that he heard a presenter, and the presenter was so proud because he said every case that he did, they always end up looking the same. And he said, you got to be kidding me, because the reality is that every patient is different and you have to tailor it to that. And I made a statement, I'm glad that people clap when Howie said, as I'm practicing more, I'm saving more teeth, and I heard people clapping. Because I think we're heading down a road of, okay, efficiency, productivity. Productivity is money, I get it, we're all working. But the bottom line is that, are we sacrificing certain things to have an outcome, but not realizing that we should be saving more teeth? There's studies to show that patients who see dentists more frequently have more tooth or missing more teeth. It's probably because we're taking them out quicker. Mm-hmm. So it has to be tailored. The short answer, it should be tailored for every patient, not one thing.
Okay.
Yeah.
Thank you.
Not cookbook.
I think I will direct the question to, I will start with how the technology is evolving. Howard was very straight on that. So we are rapidly changing and evolving, but the question will be directed to Stefan. When we consider this evolving, straightforward evolving, will someday we dentists will not need dental technicians with the new technologies, or shall we always need the human productivity, creativity?
Well, first of all, I want to thank you for having that phone call to direct me in what you wanted me to speak about. So hopefully I addressed the issues we talked about. But will we still need dental technicians, or will robotics or AI or things like that take over? The answer is I don't know. I still think that we need the artistry. I think that with digital, it's made us more efficient. But speaking to some high-level technicians, seeing like Nick Petrobon from Zurich last week, that the really skilled technicians, they feel that yes, digital has helped them become more efficient, but we maybe have forgotten the artistry. So like I've asked some of our digital technicians who are right out of school, they're like, if you didn't have the computer, would you be able to wax up a tooth? And they said no. So I think we need to understand the basics and then combine digital. It's like, asking a surgeon, experienced surgeon, when things don't go right with the guide, you need your analog ability to do that. But seeing Galib at our Aesthetic Academy meeting, he showed with robotics, and it was just amazing how he's prepping veneers with robotics. And the benefit, he said, was really that he could make the final restorations before treating the patient. So at the time of preparation, the restorations are already made. And I said, it may not have, applications for me, but he said, as dentistry is changing with DSOs, and they're hiring inexperienced new clinicians, they're the ones who are going to be using this. I'm like, wow, that was like staggering to me.
If I can just add to that, because it's such an interesting conversation, because if we look at the use of all this technology, I think the use of technology, there was a study that came out recently, and I cannot remember where it was from, but it showed that the utilization of ChatGPT is actually making our brains work less. And the question comes that when we use all this technology, how is it going to affect the youngsters of today with their hand skill, raising a flap, cutting a tooth, doing all those sort of things? Because technology is fantastic, but it also fails. Yes, like you said, how do you feel bone? How do you get that haptic feedback that actually tells you? Will the technology be able to do that? Maybe. But what happens when technology fails? Do we step back and say, oh, sorry, can't do this, go somewhere else? And how is that? I think that's going to be an interesting conversation for the future.
Yes.
To add, I think digital, if I looked at my best digital cases, they're 80% the quality of what we used to do by analog with the artistry and all the beautiful effects. I mean, we've made it more efficient, more streamlined. Newer materials make, failure, breakage less. But the artistry, I think we're losing a little identity with the artistry. And consequently, I think that, yes, robots may be able to help us, but I still think that we need to understand and have the basic understanding so we could be better on that end. And we shouldn't we're still artists, We may plan, we're architects, but we're also artists. I mean, dentistry, that's the beauty of dentistry. I think most of us went into dentistry because we had this affinity to being able to work with our hands, and we had some artistic ability as well. And we picked a profession that combined science and art. Yeah.
Thank you. I have an audience question there for Dr. Chu. Please share the workflow of immediate provisionals.
You could either have it done prefabricated for you. So with the workflow, you can design it. You could take all the different files, your Trio scan, your CBCT, to look at all the morphology. And you could actually design and fabricate your own restoration. I think Francesco Amato had published that in a book. So you could have that already pre-made for you digitally. You don't have to use some of these pre-made products. However, if you have to attach the component to, say, a tooth, and the subgingival shape is so critical, some of these newer products really address the subgingival component, which really helps the surgeon very much in their outcomes in regards to graft containment, soft tissue, socket shield, whichever you're doing in regards to being able to, provide that ultimate aesthetic outcome for your patients.
Mm-hmm. And here's a question for Professor Gluckman. The message tooth versus implant was clear. What about complex versus simple? Where is the space for simplification?
Good question. Can't answer it. I'm not sure I can answer that question. Obviously, I think without a doubt we are trying to make things as simple as we can. The utilization of technology is about simplification of the process. So wherever we can, we want to simplify. Does it mean that we can take a complex case and make a complex case simple by utilizing technology? I don't think so. I think it's still a complex case is still a complex case. A simple case is still a simple case. And I don't think technology will overcome that just yet. Maybe it will in the future, but I don't think so just yet. I don't know if I answered the question, probably not, but I'm not sure I understood it 100%.
Okay, I think this is for Dr. Chu. What do you think of abutments designed for each case without cementum, like there is a Nobel Procera ASC, for example?
Mm-hmm. You mean just without a tie base component?
You can interpret the question the way you like it.
I know that Ronnie Young works with a system that eliminates the tie base. So there's some systems that are out there that have full zirconia restorations that eliminate the need for an intermediary, component. I haven't used those, so I'm not familiar with it. But yes, the less working components you have, the less areas that could potentially fail. So that's, a factor. There are some other companies that make different types of abutments where instead of the zirconia being cemented to a titanium substructure or sleeve, that you actually can take the restoration with like a little washer underneath that's a passive abutment, and you could screw that on to sort of screw the restoration to the base versus being, cement retained per se. But yes, there are different systems out there that afford the ability not to have some of the titanium components. I know Ronnie is probably going to be speaking here, so maybe he can address some of those issues with some of the newer concepts that are out there in fabricating without going to a titanium intermediary component.
Another question here. I think it's for you again. How should we transfer temporary crown design to permanent crown?
Transfer the information?
Yeah, I guess.
Yeah. Maybe I don't think Turker I did such a good job. There's too many questions. I think I confused people. One of the simplest things is you can scan your provisional. You can just scan the undersurface. But most digital workflows work around if you've sculpted the tissue, then you do a pre-scan, you do a soft tissue scan, and then you do a scan body scan. You can also then just scan the undersurface of your provisional. Or we found with immediate therapy there's very little change. Like I said, there's very little change of the area unless you made a major mistake. And consequently, these preformed components, there's no reason why the manufacturer couldn't license or give those profiles to laboratories that would have them in their database, that you could just duplicate that ahead of time. So I don't see why that couldn't be done. But yeah, a lot of these components, it's already out there as far as the pieces. What's interesting, though, what I think is complicated is the following. If say that I want to design a custom angulated abutment, because I need to customize it, but I need to also have angle correction in it. If I don't pick the correct scan body for the manufacturer that can provide that service, then I have to see the patient again because I've used the wrong scan body. And that becomes a problem. Like I said, it's very complicated. So you have to know that or work with your laboratory. And speaking to Nick Petrobone last week, he goes, Steve, maybe we have to go back to an analog, where you take an analog impression, and then the lab can then scan it to file, and then the lab has all the flexibility to design whatever is needed for that case. Going back to analog, that's what he told me. Nick Petrobone is a great lab technician from Zurich. So
I think
it's fascinating.
We are getting now close to closing this session. We have had some wonderful presentations from all of you.
Björn,
yes?
before you close, may I ask a question to Ben?
Actually, I'll check with the other speakers here. Yes,
Okay.
it's okay.
Yes.
You do it.
Yeah.
Sure.
Okay, Ben, thank you very much for your calculation what the universe is going to be in 1 billion years later. Very interesting. If you come back to present time, what do you think about this climate change issue? Is it real?
Of course. It's very real and very scary. That's why I put a 50-50 chance on humanity surviving for the next 100,000 years. There is numerous lines of evidence, but
You're still scary.
I'm very concerned for my children. Yeah, very.
Thank you.
Thank you so much, all of you. There is actually one last question for you, Ben. You don't have to answer it publicly, but there is one here who would like to know how long you are staying and if it's possible in the break to have a personal discussion of eternity of. So it could be a long discussion, I assume.
Of course, I'm here all day and for dinner tonight, and happy to have some drinks and answer philosophical questions.
I think that was a very, very good answer. Offering drinks to all speakers would be a very good way to have more answers to problematic questions. Thank you all for staying here, and thank you all for joining the session.
Thank you.
Thank you.
Thank you. You did a great job, and you had all these images. I saw that so cool.